Certainly true that it's going to take some time to develop the teams and the processes to allow this to happen. Yet, there are well-established endovascular treatment facilities all across North America, Western Europe. Endovascular treatment is used for management of aneurysms, for other conditions as well. So the navigability or the expertise to do the procedure is available. There are comprehensive stroke centers all across North America. I think the key thing, though, is going to be how do we move people to the right place at the right time? Because it is now going to be unacceptable to send a patient to a primary care hospital with a middle cerebral artery occlusion when they could have gone 15 minutes down the road to a comprehensive center and received essentially definitive and life-saving therapy. And again, I would emphasize that the technology is terrific. It is enabling, no doubt, but it's the combination of imaging, really fast workflow, and technology that has allowed us to show these results. But you're quite right. We have to push stroke into the pre-hospital arena, get more, get involvement of the pre-hospital system in a much bigger way, and really decide what's the best way to triage people to places where this therapy can be delivered. Well, what we've seen is that the Dutch group, the Mr. Clean group, presented their trial results in October, the end of October, at the World Stroke Congress this year, and then 4 trials have come together. Escape was the largest of the 4, or sorry, the 3 that were presented today. The Mr. Clean was presented in addition, and shows us that the combination seems to result in a kind of like a triple whammy to say that this really needs to be the standard of care. Well, I think there probably are a couple of different things. One is that we still need to recognize that 45% of our patients are still disabled. So there's still lots to do, and the question is what's going to be the best way to achieve that. For sure, a major issue is going to be how to get the right patient to the right place at the right time. And so there's going to need to be a real rethinking about how to do that. And it's not going to be the same in every place. It's going to vary by geography and expertise and that kind of thing. So that's a key thing. So that's what I would call the knowledge translation. How do we move this into practice? I think there still needs to be technical improvements. The devices are fantastic, but can there be improvement? Sure there can. And there needs to be training, right? We need training and technique, and we need people who are able to do this and manage it. And we're going to need to do, certainly on our data, we're going to need to spend some time thinking about economics and how do we show people that this is worth it. It's very clear, certainly in my mind, that there certainly is a small upfront cost. You're investing in an acute treatment and a team, but the downstream benefits in terms of keeping people out of nursing homes, getting them back to their families and their jobs is massive. So I'm certain that we will show a cost-effective, and cost-benefit analysis will show that it's massively cost-effective, but we're going to have to work out how to merge those two things together.